Good morning or afternoon to everyone. We're very excited to have you here with us today to talk about the 2025 hospice payment rate proposed rule. We have our Vice President of Quality, Standards, and Compliance here with us today, Jennifer Kennedy, and she is going to give you all an update. Really quickly, the slides will be available. We'll send them out via email at the end of the presentation. There'll also be something you can grab out of the chat once the meeting has closed. For now, if you have any questions throughout the presentation, please use the Q&A to post your questions. If we can answer them quickly, we will. Otherwise, we will hold the questions to the end of the presentation and address them all at one time. Thank you so much. Go ahead, Jennifer.
Thanks, Denise, and welcome everyone. Thanks for taking some time out of your day to learn what's in the pipeline for hospice. So first of all, we'll talk about the proposed payment rate update. And before I get to that, just to give you an FYI, the official proposed rule posted in the Federal Register on April 4th. If you're planning to make comments, which I encourage everyone on this call to send a comment letter, and that is going to be due on May 28th, and we would expect the final rule to be posted somewhere in early August of this year. So let's talk about what's going to happen with rates. We have a proposed 2.6 rate update on the table. And that's good news. Remember, that's a national update, so you would need to look at the specific state and county wage adjustment to see what that would look like for you. But just a quick reminder that we still have sequestration in place. That is a 2% deduction, and that goes in as soon as you send a claim in. So it's really if this stands in the final rule, you're not actually getting a 2.6% update with sequestration in place and then your wage adjustment for state and county. CMS is also proposing to adopt the most recent OMB statistical area delineations. What this means is that the CBSAs are mapped and based on data collected during census collection. So hospices affected by that change in their geographic area would be eligible for applying a 5% cap on any decrease to the wage index from any prior year. When we're looking at the proposed hospice cap for 2025, it is $34,364.85 compared to $33,494.01 from the 2024 fiscal year. So this is what your rates would look like. Again, these are national. So your tier 1 of routine home care would be at $223.83. The tier 2 would be at $176.39. And then for your other levels of care, you can see here that that 2.6 bump would give you $1,610.34 for your continuous home care, $518.15 for your respite, and $1,166, let's call it $167 for GIP. Just a reminder, if you do not submit quality data, or if you submit quality data that is not either at the HIS threshold, or your CAPS vendor did not send something in on time, you would be subjected to a 4% reduction from a coordinating fiscal year market basket update. So those are your rates. Again, we'll see what we look like on the final rule and whether that 2.6 will stick. CMS did include proposed regulatory updates, and these are mostly looking at language, leveling language in the regulatory text. So let's talk about what some of those changes will look like. The first thing is physician language. CMS did note and identify there were language discrepancies in existing regulatory text as it relates to the medical director and physician designee. These are both in the COPs and in the conditions of coverage. So just, to back up 1 second, your COPs are your subpart C, your subpart D. Those are patient care, those are organizational. When we're talking about coverage regulations, those are all the regulations that are encompassed in subpart B of the federal hospice regulations. So those are your things like certification and discharge and admission and transfer, election of hospice. All of those things are grouped into the coverage regulations. So when we look at the language in the COPs, the medical director or the designee is the person or persons to review clinical information and provide that written certification for hospice care. But when we look at the coverage regulations at 41822, certification of terminal illness, the language states the medical director or the hospice physician member of the IDG can certify terminal illness. So we have discrepancy in the language of who can actually do that. The issue that it's created here is really one of review audits. When you're looking at different auditors that are out there looking at your clinical records, or it could be a survey issue as well, because we have discrepancy in the language of those two federal regulations. This misalignment has caused confusion for hospice providers, accrediting bodies, surveyors, and even auditors at this point. What CMS proposes to do is to amend 418.102 in the COPs and add the physician member of the hospice IDG as someone who can certify. And they're also proposing to amend the medical director COP to include medical director, physician designee, as it's defined in the definitions. If the medical director isn't available, then the physician member of the IDG could review clinical information and make a certification and recertification action. So same kind of thing when we're talking about the CTI and the admission to hospice care. In the current regulatory text, the attending physician and the hospice medical director or physician member of the hospice IDG can certify a patient's terminal illness in the first 90-day period of hospice care. And then in the subsequent 90 or following 60-day periods of hospice care, only the hospice medical director or the physician member of the IDG recertifies hospice care for that particular benefit period. So the COPs at the medical director 418.102 state again, when the medical director is not available, that physician designee would assume the responsibilities. And then in the coverage regulations at 418.25, admission to hospice, there's only reference to the recommendation of the hospice medical director in consultation with the attending physician in determining admission to hospice. So again, we have misalignment of language in these different pieces of the federal regulations. And that misalignment, again, has caused confusion for hospice providers, accreditation bodies, and state surveyors. So CMS is proposing to align the language. They propose to add physician designee to clarify when the medical director is not available. A physician designated by the hospice would take on those responsibilities of the medical director, including certification. And CMS, in both of these examples of aligning the language in this example and the previous example, CMS does not see this as a change in policy, but rather just aligning language. So it's not going to be any change in process or policy of what you do. It'll just be aligned language when CMS finally updates the different pieces, which would be the federal regulations. They'll update CMS Chapter 9 and any other pieces. Finally, there is alignment due to confusion between the hospice election statement and the notice of election, the NOE. Right here, you see the definition, which is the difference of two. The hospice election statement is actually what your patient or representative signs to receive hospice care. The notice of the election is something the hospice files with their Medicare administrative contractor within 5 calendar days of the effective date of that hospice election. These terms have been used interchangeably over the years. And when discussing hospice election, stakeholders like your MAC and medical reviewers and hospices often use those terms interchangeably, and they're very much different when you look at the definitions. So CMS over the years has received inquiries basically saying, could you please align this, because it is confusing to the hospice community and stakeholders attached to hospice. So CMS reviewed the regulation. They believe that at 41824, it does not make it clear that these are two separate and distinct documents for two different purposes. So what they're going to propose to do, or what they are proposing to do, is to reorganize the language to denote the differences between the election statement and the NOE. And these changes would align with existing sub-regulatory guidance. And again, this would not be a policy change, but it is intended to more clearly identify and define the differences between these two forms and processes. All right, so those were all of the regulatory-based changes, and that really wasn't much in terms of change, because it really isn't. It's more of alignment of language. CMS it did post a request for information in this rule, and this is where I really want all of you to look at this and consider, very seriously consider submitting comments about your thoughts. CMS is asking the hospice community for their feedback. This is your open invitation to tell them the good, the bad, and the ugly regarding what they're asking about. CMS does acknowledge that there's a portion of hospice eligible patients out there that could benefit from a palliative care approach versus curative. But some of the treatments that they're receiving for palliative care reasons shut them out from accessing hospice care, such as palliative chemotherapy or radiation or blood transfers, even dialysis. So CMS has heard back from their beneficiaries and their families that they're concerned about being shut out from hospice services because they are opting to continue these various treatments as examples on a palliative mindset versus a curative mindset. So CMS did ask for comments in the fiscal year 2025 hospice rule And they talked about providing complex palliative treatments in higher intensity levels of care and the financial risks that are connected when you're taking on patients that need these things. What they gleaned from the feedback of that last year's rule was that the current bundling of that per diem payment that you receive does not cover the increased expenses that come along with patients wanting these palliative care treatments. So with that in mind, CMS now is asking you your thoughts of additional feedback on this topic. So you can see here some of the things that they're asking about would be elimination or what could eliminate financial risk. Commenters previously noted related to providing complex palliative treatments and these higher intensities of care. And they're asking you about the risk. What are they specifically? What are the costs specifically that would prevent you from taking a patient who, say, wanted blood transfusions or palliative radiation? They're asking you, should there be any types of parameters around when these palliative treatments would qualify for a different level of payment? So, possibly a different payment structure that would be a little more in order for hospice providers to take these cases. Under the current hospice benefit, palliative care is defined as patient and family center, and that optimizes quality of care, as you can see here. And they want to know, should there be documentation that all other palliative measures have been exhausted before billing for a payment for a high cost of treatment? And if so, would that continue to be a barrier for you as a hospice provider? And finally, should there be separate payments for different types of higher cost palliative treatments, or just one standard bucket payment for higher cost treatment that would exceed the per diem rate? These are very insightful questions. We do indeed, I think, have an access issue for patients who want these types of treatments. They're no longer looking for curative care, but these actual palliative treatments are helpful to them as they are on their journey in hospice care. So I think it would be beneficial if everyone could think about submitting comments and what that would mean and look like to you in response to those questions. If you have questions, we'll take them at the end, and perhaps you have questions about that section. So let's talk about what I think is the star of the show of this rule, and it's in the quality section. CMS is talking again about new quality measures they intend to implement. There are 2 new process measures that will be added to the HQRP once the implementation of the HOPE assessment tool is completed. So the 2 measures are timely reassessment of pain impact and timely reassessment of non-pain symptom impact. They are expecting the collection of data for these 2 measures not to happen before fiscal year 2028. These process measures would reflect whether a follow-up visit occurred within that 48-hour time frame of the initial assessment, where the hospice team was evaluating the impact of moderate or severe symptoms with or without pain. This is not new. CMS talked about these 2 measures in the last year's rule, and what we saw in 2023 activity, that these 2 proposed measures were actually submitted to the measures under consideration list in this past December, went to that panel for evaluation, And now we are taking the next steps to making these measures a reality. Testing of these two proposed measures was something that happened in the HOPE beta test, which was the last test of the HOPE assessment tool. And CMS will implement these measures and propose future measures when the HOPE assessment has been implemented nationally. So CMS is saying for both of these measures, they're proposing that the collection of data would only occur with in-person visits in order for it to count for the measure. And what they're asking is, do you think that it should be only in person, or would it be appropriate for the collection of this data to happen in another type of visit, such as a telehealth visit? So they are asking your feedback about this particular item. Again, this is an ample opportunity for you to tell CMS what you think. And, whether you think in-person would be good, or it should be in-person or telehealth with qualifiers, they want to know what you think. CMS also proposes that a follow-up visit can't be the same visit as the initial assessment, but can occur later on the same day as a separate visit. When we're looking at the numerators for both these measures, CMS is proposing that it will be beneficiaries who received a timely symptom reassessment, and these would be beneficiaries, obviously, who receive a separate HOPE reassessment within 2 calendar days of that initial assessment. The denominators for these measures, CMS is proposing that beneficiaries would be included if they have a moderate or severe level of pain or non-pain symptom impact at their initial assessment. And there would be exclusions, as you can see here. So if a patient is discharged alive before the 2-day window, if the patient or caregiver refused the reassessment visit, if the hospice was unable to contact the patient or caregiver to perform the reassessment, if the patient traveled outside the service area, or if the patient was in the ER or the hospital during that 2-day follow-up window, all of those would qualify as exclusions for the measures. CMS also talked about some other HOPE-based measure concepts that are under consideration. 2 of them that were mentioned in the rule here was education for medication management and wound management addressed in the plan of care. So you can read more information about these measures and recommendations from the technical expert panel that was engaged to look at the HOPE assessment tool and possible measures. And I've given you a link in the slides for that. All right, so let's talk about the biggest, I think, item in this proposed rule, which is the hospice outcomes and patient evaluation, or the HOPE assessment tool. We've been waiting for years now while CMS has developed the tool, tested the tool on 3 different levels, and now we're at the point where CMS is talking about implementation of the tool nationwide. What they're proposing to do is to adopt and implement the HOPE tool starting October 1st, 2025. That would include implementation of requiring hospices to use this tool and submit a standardized set of items for every patient that you're taking care of to capture that patient level data. And it's regardless of the patient's payer source or the patient's age, which is similar to the OACC collection. That HOPE tool would replace the hospice item set. So HIS would go away, a HOPE tool would be coming in. And in terms of the penalty, if the HOPE tool data is not submitted, or if it's not submitted with the proper threshold, which is going to be 90%, same as the HIS, you would receive a 4% reduction on a coordinating fiscal year. CMS has been saying that they've been wanting to implement this standardized tool because it's going to help them develop patient level data during the entire hospice stay to help and develop and support quality measures as well as future payment models. So when you look at the information in the rule and the draft manual that CMS has made available, the HOPE will collect data at multiple time points across that patient's hospice stay. And it will include admission, as well as the HOPE update visit, the HUV, and discharge. Now, the hospice update visit is going to be dependent on how long that patient has stayed with you for care, and it is limited to a subset of HOPE items that address clinical issues that are important to patient care of the patient and updates to the hospice plan of care. So it's going to be a very streamlined set of items and not the entire assessment. The patient is going to need to be over the age of 18 and regardless of payer source. The HOPE will collect information on several domains such as socio-demographic, diagnoses, symptom impact, and imminent death. Some of the proposed data elements represented in those domains fall under an administrative category, preferences for care and routine activities, restricting it to active diagnoses, health conditions, medications, and skin conditions, which I can only assume is wounds. As I mentioned, the data collection will begin October 1st, 2025. There on that date or shortly thereafter. And when that does kick, hospices would no longer need to collect and submit the hospice item set data points. When we're looking at the projected public reporting of HOPE content, CMS is saying no earlier than calendar year 2027 that they would be reporting quality measures that are hooked to the HOPE. So that would be those two proposed measures to start with. CMS does need that data for a period of time in order to validate and look at it to make sure that the measure works, and that implementation would be coordinated with the fiscal year 2028 payment update. In tandem with that public reporting, CMS needs time to establish reliability and validity of those measures, and they need a minimum of 4 quarters of data, maybe even a little more. So what CMS is proposing here is that the data from the first quarter, which would be quarter 4, calendar year 2025, if HOPE begins when they're saying it would begin, would not be used to assess validity and reliability. CMS would consider public reporting using fewer than 4 quarters of data for the initial reporting period, but they would propose ideally to use 4 quarters of data as the standard reporting period for future public reporting. CMS will propose the timeline for public reporting of data in future rules. So we'll be watching that, and we'll see more information come about what their timeline is going to look like for reporting out down the line. At the time of the HOPE implementation, all HOPE records will need to be submitted as XML files. That's the same as you do for HIS. And you would need to use a vendor software to submit your records to CMS. CMS will provide technical data specs to software developers and vendors on the website, I would assume once the rule is final. And software developers and vendors are encouraged not to wait for the final tech data specifications to start building and developing their products. So that's your EMR vendor. They should be looking at this proposed rule and already figuring out how they're going to build that in their current platform. CMS does plan to conduct a call with software developers and vendors after the draft specs are posted. Again, I would assume that is going to be once the rule is posted as final. If you are one of those hospices out there using the hospice abstraction reporting tool or HART, that will be retired. It will no longer be provided as a free tool for standardized data collection. And beginning October 1st, 2025, as I mentioned before, you will need to select a private vendor to collect and submit your HIS data and subsequently HOPE data to CMS. Now, let's talk about compliance requirements for HOPE. The HIS submission for compliance is currently at 90%. That's the threshold. Have to be submitted and accepted. I wish I could put that in 52 font and accepted within that 30-day submission deadline to avoid that deduction, 4% deduction penalty. What CMS is proposing is to apply the same submission requirements for HOPE admission, discharge, and those two HUV records. After HIS is phased out, CMS would apply the 90% threshold to all HOPE records that are submitted to CMS in that 30-day window in order to measure your compliance. Again, hospice providers that fail to submit all of their HOPE assessments to CMS for at least 90% of their patients would be subjected to the 4% reduction. Now, we would expect CMS to provide us training as a hospice community, and they did state that they would do that. They will provide information about upcoming provider and vendor trainings related to the HOPE version 1. And that will appear on the CMS HQRP webpage in the announcement section. And again, I wouldn't think that we're going to see training announcements until after the final rule has posted. But right now, we do have the draft HOPE guidance manual version 1 on the HQR webpage under HOPE. So you can start looking at that manual right now to get an idea of the structure of the tool. And I would even start showing it to your staff who are going to be completing that tool so that they have an idea of what the questions are going to look like and how they would structure their answers. So that's the HOPE assessment tool. CMS did put in another request for information related to health equity. CMS has been focusing on health equity for a number of years now, and they do believe that measurement of social determinants of health will be a huge benefit. By measuring SDOH, providers would have the information they need to identify disparities in their patient populations, in your service area, the communities that you serve, and health outcomes. And if you have better SDOH quality measures, which CMS would use any kind of data to build down the line, that would help to inform more effective programs and help them target and mitigate disparity in health equity. Also, thorough SDOH measures would also provide a better evidence base for evaluating effectiveness and appropriateness of health and social care delivery innovations. So the SDOH category of standardized patient assessment data elements, i.e. what's embedded in the OACC tool, what will be embedded in HOPE, and possibly moving forward with broader collections and subsequent versions of HOPE, that could provide you, a hospice provider, and policymakers with meaningful measurement to reduce disparity and improve care for all beneficiaries with social risks. So here comes what CMS wants to know from you. They have potential data collection items related to 4 SDOH domains. So housing instability, food insecurity, utility challenges, i.e. lack of energy, electric, gas, etc., and transportation challenges. CMS wants to know whether you think these items are relevant for hospice patients and their caregivers or caregivers, which of these items would be most suitable for hospice, how these items need to be adapted to improve the relevance for hospice patients and their caregivers. So would you recommend adjusting the timeframes or items, etc.? Would you recommend revising any of the items response options? And are there any additional SDOH domains that you think would be helpful for identifying and addressing health equity issues in hospice? So that's another wonderful opportunity for you based on what you're doing in your hospice, in your area, in your community, to give thoughtful feedback to CMS before they just go ahead and decide what they're going to do with no feedback. It's important that everybody weigh in. All right, CMS did put out some updates, proposed updates as it relates to the CAHPS survey and measure changes for CAHPS. They have developed a new survey. It is shorter, it is simpler than the current 42 item question, and it does include new questions on topics that were suggested by stakeholders. So here are the proposed changes to not only the survey, but the quality measures. They're removing 3 nursing home items and an item about moving the family member that is not included in scored measures. They're proposing to remove 1 survey item regarding confusing or contradictory information from the hospice team communication measure. They're proposing replacement of the multi-item Getting Hospice Care Training measure 31 with a new 1-item summary measure. They're proposing addition of 2 new items, which will be used to calculate a new care preferences measure. And they're proposing simplified wording to the component items in the hospice team communication, getting timely care, and treating family member with respect measures. CMS is proposing to launch this shorter survey with those changes beginning with January 2025 decedents. And we will also provide a handout that has a cutout table of the side-by-side of the current CAHPS survey with the proposed CAHPS survey so that you can have an easy look and not have to dig through the rule for that. CMS is seeking comment on these proposed changes before the finalization. So here's yet another chance for you to provide your feedback. Let's look at some of the proposed changes for the measures. In care preferences, CMS proposes to wait to introduce public reporting until it has 8 quarters of data, since it is updating this particular measure. I'm sorry, not updating. This is a new measure for CAHPS. So they're proposing not to do any public reporting until they have a minimum of 8 quarters of data. The next one is a revised measure, getting hospice care training measure. So CMS believes that the change, moving it from a multi-item to a one summary item, is substantive, and that revised measure should be treated as new for purposes of public reporting and star rating. So they're proposing not to publicly report the new version of getting hospice care training, again, until there are 8 quarters of data. CMS anticipates that the first care compare refresh, in which we would see publicly reported measure scores with these updated measures with the new survey, would be in November 2027, with scores calculated using data from Q1 2025 through Q4 2026. What kind of impact will all of this change have on your star ratings? The hospice team communication measure, they're only removing one item and slight wording changes. So CMS believes that it is non-substantive and would not have an impact on star ratings. The transition period. So during the transition period, scores and star ratings would be calculated by combining scores from quarters using the current and the new survey. And CMS proposes that family caregiver star rating summary would be based on 7 measures rather than the current 8 measures during that transition period, until they have a full 8 quarters of data available for the getting hospice care training measure. The summary star rating would be based on 9 measures once 8 quarters of data are available for the new care preferences and getting hospice care hospice care training measures. So the proposed rule includes changes to the overall rating of this hospice measure, and again, non-substantive, and would impact the special focus program algorithm as well. In terms of survey modes, CMS is proposing that the following would happen as it relates to administration of the CAHPS hospice survey. They would add a web mail mode, meaning that a caregiver would receive an email invitation to a web survey with mail follow-up to non-responders. They would add a pre-notification letter, and they would extend the field period from 42 days to 49 days. Again, the implementation for these changes is proposed beginning with January 2025 decedents. So that's a lot to take in. What can you do now with all of the information that I reviewed with you? I would say, if you haven't looked at that proposed rule and any available summaries, which CHAP did put out a summary for you, you need to understand all the content, CMS proposals, as well as the opportunities of areas where you can provide your feedback. Please, please, please submit a comment letter to CMS with your feedback. That is due on May 28th, 2024. Educate your staff about proposed items in the rule so they know what is coming, particularly about that draft HOPE guidance manual. I let them know the timetable of when CMS is hoping to roll this HOPE assessment tool out and make that the information in that draft guidance manual available to your staff. Do some structured, training or tabletop, get their feedback. All of that's going to be important leading up to implementation. Maybe it's even a HOPE implementation work group that you develop. I would, right now, if we're back in a hospice, I would be cultivating ambassadors or champions from the hospice team to help with this effort of the change from what we have now to the HOPE assessment tool. You're going to need to develop your budget for 2025 if you've not already done that or you're in the process, to include cost and resources for HOPE implementation. And then obviously you're going to need to have someone who's monitoring that CMS HQRP website for updates. All right, so we're at the point now, Denise, where if there are questions, I think we can take them.
We do have a few questions here. So let's see. There's a question, our most recent question that was posed was, do you have a link or a pathway for where on the CMS website you can submit the RFI?
Yeah, so you can submit a comment letter, or, usually it's a letter that you submit, which has all the feedback that you want to provide. When you look at the beginning of the hospice proposed rule, right on that first page, there is information and a link for where you send your letter.
Okay, great. The next question is actually about the HOPE assessment. It says, will the HOPE be submitted the same way that the HIS is submitted?
So it looks like the file type is the same, and I'm not, I've not been in the provider realm for submitting HIS data, but I'm assuming you're using some type of abstraction software. Maybe it's through your EMR. You're definitely going to have vendor software in order to submit HOPE data.
Thank you. Question here, it says, I'm curious about the NOE and election statement being on one document together for one signature instead of them signing two different forms. Would this be allowed? And should we go back and have patients or families re-sign two separate documents?
Okay, so again, this is why we're getting the regulatory alignment, because there's confusion about these two documents. The only document that your patient or representative signs is the hospice election statement, right? The NOE, the notice of election, is an internal document that you are sending to your MAC. There is no signature from the patient or representative on that document.
Thank you. Question here about HOPE and HIS. Question is, isn't the HIS going away altogether?
Yes, the HIS will go away altogether once the HOPE is implemented nationally. So what the proposed rule is saying is that the October 1 is go. It's the go date when you're going to start submitting your HOPE data. So I would assume there will be a crossover period, and we will receive, I would think, more direction on what that transition period is going to look like in future rulemaking or sub-regulatory guidance. I'm thinking it's probably going to be sub-regulatory guidance if CMS decides that October 1, 2025 is the go date.
Thank you. Any thoughts regarding separation of facility-based CAHPS respondents from home-based respondents?
CMS doesn't address that, so if you decide to do that, that would be at your organization's discretion. All I know is that you have to have 100%. 100% of your patients, caregivers need to have a survey sent to them. Whether they choose to respond or not, that's at their discretion.
That is all the questions we currently have posted in here. I'm going to reiterate for everyone that the recording of this session is available on the registration page. And I have turned on the chat, so if you pop in there, you'll see the slides for this presentation are attached as a file. And we will also send a follow-up email to everyone that includes those slides as well. We do
We'll
just have
also
in
include
here,
that handout, Denise, the one I talked about.
thank you. Great, as well as the handout. And then you'll see that we've posted in the chat as well a link to this as well. So that should be helpful to everyone. I'm just double checking to make sure we didn't get any more questions that came in. I think that's it.
Does anyone want to tell me how you feel about all of this? Do we have any brave souls who want to just let me know what you think?
You're opening up a can of worms there.
I might be. That's okay.
If anyone wants to use the chat to comment on that, please feel free, or to post it in the Q&A. We do have a comment. It says, it's great for me working for an EMR. We need to know what's up. Thanks, Ashley.
Yes, yeah, you surely do. So please watch CMS carefully.
We also have someone said they're stressed. We said overall don't have many concerns yet. The EMR will be a savior. Love the changes to CAPS. I'm sure everyone is very happy to see the possibility for electronic submission. Would love for palliative treatments like radiation to be covered by the hospice benefit.
Yay!
Excited about the possibility of coverage for palliative.
Yeah. Please, please, please. This is like, there's a lot of requests for information in this role, but I think the biggest one here is that palliative care one. We want CMS to get the taste of reality, right? Before they arbitrarily just develop payment that makes no sense if that's what they're going to do. Please, please, please comment on that.
We did have a comment that says palliative versus true hospice care and bundled payments is concerning. I doubt they will pay for that, but I do hope they provide it.
Yeah, that's a great comment. You know, if I were queen for a day, I would kick the old benefit out the door because it's antiquated. It doesn't meet the needs of today's healthcare continuum. I would love to see just a palliative care continuum where you have seriously ill patients on this end, you have your terminally ill on this end, and there would be payment to cover that entire swath of patients. But I'm not queen for a day, so please submit your comments.
Another comment over here just about EMRs that says hope will add lots of extra visits and be challenging for hospices in rural areas. Another concern about HOPE assessments being in person, including the timely reassessment for moderate and severe symptoms, even to document that moderate pain at admission was resolved, requires in-person assessment.
Mm-hmm.
Says
in-person visits could be challenging.
The in-person is challenging.
Yeah, and if you think so, you know, think about this. You got to think about it and pull that thread through. If you think telehealth should be included, that's a great comment to submit to CMS. But then you have to think, how am I going to assess that? How am I going to measure that? If you have, you know, if you can think about how you would do that and it would meet the need and the requirement, then I would say, yeah, go ahead and make the suggestion for telehealth as well as in person.
So there is a clarifying question around that. It said possibly telehealth for the follow-up visits. Is that something that has not been fully worked out yet?
So it sounds like they're not married to it yet. So, you know, if they're asking, they're saying right now we're proposing in-person only visits for that 48-hour follow-up visit, but we're open to hearing what you have to say. We want your feedback. So again, when CMS opens the door, you go ahead and let them know. I always say, give them the reality check, okay, about is it challenging? Is it not challenging? Are there alternatives? All of that should be things that you let them know. If you do not submit your feedback, then I feel like you don't have a reason to gripe on the back end, okay? Because you have the opportunity, as you know, Hospice ABC, to let them know how it works in your neck of the woods, okay? So do it. Take a few minutes, let them know what's your feedback.
Awesome. For someone who is unable to see the files, the slides, they're going to be all the way at the top of the chat. So you might have to scroll up in order to see those files. But again, we will send out a follow-up email to everyone and include the slides and resources, as well as a link to the recording if this is something that you want to listen to again or share with others in your agency. We are about 5 minutes early, but I think we've covered all the comments and all the questions. We really want to thank everybody for showing up today. We had a great turnout. We hope the information is helpful to you all. And special thanks to Jennifer for taking the time to put this all together for us. We do have a hospice operations workshop coming up at the end of June. That'll be located in the middle of the country. So we're going to have that in San Antonio, Texas. And we will cover topics of compliance, including these type of things. So we'd love to see some of you join us for that.
Yeah, come spend some time with me. Love to have you. Yeah, Annette, it is a lot, isn't it? I see my friend Annette Kaiser there. Ugh, it's a lot. Yes, it is a ton.
Well, thank you, everybody. Have a great rest of your work week and a great rest of your day.
Thanks again. Thanks for all you do.